bother all of you at these hours of the day when you all want to sleep. After such a good food, very tasty it was. And thanks to the organizer for having given me an opportunity to come here and talk. I was almost non-existent on their mailing list. Somehow I got into it 4 or 5 days ago, and they saw to it that I would be here. So thank you, Miriam, Vandana, and all others at Banyan. I would straight go to the slides. I hope to take only 10 minutes, not more than that. I hope I am able to contribute a little bit to the discussion. More than contributing, I am taking back a lot of things from here, and I am happy to know that so many things are happening in south of India and so many initiatives, and probably that should give us a kick somewhere in the western region. With help of Bhargavi, maybe we can do something more. Okay, so coming back to organization, we are called Trust for Reaching the Unreached, and as the name signifies, we want to reach out to the people who have not reached to the services, and we always give that motto to our workers also, that person who is not coming to you is the one that we have to reach. So that's how we have tried to reach. I have so many slides about the organization and where, what we do, etc., etc. I won't go into much of the details. Basically, we are a health group. We started way back in 1970s. We picked up from the Jayprakash Narayan's movement and Bhudan movement, and then we were part of Tarun Shanti Sena. That was the All India Peace Corps, and then Medico Friends Circle, we were among the founder members, and then whole journey into Gujarat, and we have networked with lots of organizations. We have brought new ideas to Gujarat, and we have tried to bring community health movement to the Gujarat scenario, because at that time health meant only within the four walls of the dispensaries or hospitals. Then came the women-centered approach, the family planning policies, the resistance against long-acting contraceptives, then rational therapy, what we call correct use of medicines. We have our contribution to that movement, and then came our Kutch disaster, that we had the earthquake. We got so busy in the earthquake that we left most of the networking, except for contributing to organization of People's Health Assembly, which maybe some of you have witnessed. Now it is called Janaswasthya Abhiyan, and probably Gujarat was one of the best People's Health Assembly held at that time, and that was our beat of mobilization. Anyhow, now we are on to the mental health. Everything started from our vital statistics program, that we keep on collecting vital statistics, the birth and death and marriages and all sorts of things. And out of that, the death data was saying that 2002 and 2003, we had lots of suicides. I mean, the rate had increased somehow from maybe 2 to 3, I mean 0.2 to 3 per thousand to 8 per thousand and things like that. And we thought something is happening in the community, and we wanted to do something about it. Very new to the field of mental health, we were not knowing P of psychiatry at that time. Myself and my doctor colleague is a pediatrician and also an epidemiologist. We ourselves underwent a little bit of training, little bit of self-learning. We went through the textbooks, we went through some of the lay counselors training at that time were being held by, I'm forgetting her name, but we attended that, and we thought, yeah, let's do something about it. And at the same time, IIM was searching for good organizations who can pick up some of the activities in mental health. They found us and they approached us saying that, can you pick on a program? We said, well, the best we can do is we would like to integrate it into general health. That's our goal, and because we want that the general healthcare worker should also look after the psychiatric care of community psychiatry. And that's how we started working. We have done, although 4 years of our journey, 5 years of our journey, we've done very little. But to my credit, we have about 1200 patients who have been looked after, and for last 1 year we have started functioning at 2 blocks. I will just come to the story of what we did with community mental health program. Yeah. This is India, Gujarat, and Panchmahal, which is one of the most backward districts of India. There are 20 districts which have been labeled as most backward. We work in Panchmahal and Baroda, and as our name says, we work on all taluka borders. Our project area cuts across about 8 talukas. Taluk, you know, no? So 8 taluks it cuts across, and it's all full of forest and hills and ravines and things like that. These activities in a nutshell. This is research and publications. Area and people where we worked. Maybe you're not interested. Community health components. We have all the community health components as much as we could do in our this thing. New interventions. We also are trying to take care of the hypertensions and diabetes, and in a community way, you know, and also like wanting to do a lot for mental health, and all other illnesses are there. Go further. Okay, so now we are on the mental health. Our motto has been affordable, accessible, rational, regular, and culturally suitable services for disadvantaged people. What we did? We were told that you cannot deal with psychotropic drugs because none of you is a psychiatric graduate. So we said, okay, fine. We got hold of one of the psychiatrists. He was there. He used to come once in a fortnight. Mohan Isaac knows. He was not interested at all. He was not interested at all in anything that was happening in the community. Maybe he was junior to you. Okay.
Not my fault.
Well, oh, you have moved out of Gujarat, so that is your fault. Yeah, so integration of mental health, integration points. Now, what best we could do? We could train our general healthcare workers for mental health in identification, referral, follow-up, family counseling, and if possible, community-based rehabilitation for the MI patients. We incorporated mental health issues in all our general healthcare programs. You know, we used to have extensive education program for maternal care, child care, for TB, for immunization, for these, that, and also the communicable diseases and all that. So everywhere we would go with 1 or 2 messages for awareness and stigma reduction. And all these sort of, you know, helped us to create some awareness in the community, and psychiatric patients started coming in. Then the responsibility on us was also to like develop some tools which we could use with our workers, which our workers can use on their own to identify patients and all that. So we have drawn a symptom checklist for identification and referral of patients. We have couple of manuals which I will come back to. We have also developed a follow-up form that helps the worker to assess how much is the improvement in the patient's illness. Then image education for awareness and stigma. We did all kinds of things, campaigns, patrikas, posters, booklet, Arogya magazine we had, street plays, songs, sensitization training for PHC and CHC doctors, paramedics, focus group discussions, etc. One little note on our experience with training of PHC, CHC, which was part of DMHP. Like DMHP told us that why don't you do IEC and training of doctors. So we said fine, but look, we are a small NGO, we don't want to take up the whole